Welcome to everybody. It's a pleasure for me to introduce Professor Olimpia Musumeci. She's a professor in neurology at the University of Messina, and she will talk today about progressive external ophthalmoplegia and differential diagnosis. This is the last webinar of this series on mitochondrial disorders, and it's a very nice conclusion for this ERN series of webinars. Thank you.
Many thanks, Chiara, and it's a very pleasure and honor to be here this afternoon. And I want first to thank you, the ERN, EAN, for these webinars that are very educational and are very nice for everybody, either expert or younger. And the topic will be progressive external ophthalmoplegia. And as we know, we want to define simply ophthalmoplegia is a dysfunction of eye movement that we know they are they are involvement in the movement of the eye. And when we talk about ocular motility dysfunction that are frequent present in different neuromuscular disorder, three main symptoms can derive from this dysfunction. First of all, patient can have an eyelid ptosis that can be unilateral, bilateral, can be fixed, can be fluctuant. They have a limitation in the eye movement, that is the topic of our presentation, and they can have another symptom that is not always present in the presence of an ocular motility dysfunction, and that is the diplopia. When the clue in the diagnostic approach of ophthalmoplegia, or either ophthalmoparesis with the eyelid ptosis or without, has to consider several points. First of all, the onset. It can be acute or chronic. It can be, the clinical course can be stable, fluctuating over the hours, over the days, can be progressive, can be distributed to both eyes, so bilateral or either unilateral, can be symmetric or asymmetric, can be associated with pain, and can be associated with other signs, either neurological or extra-neurological symptoms. When we talk about EOM dysfunction in neuromuscular disorders, we can distinguish three groups. We can have a dysfunction in the eye motility because of a nerve dysfunction. We can have a dysfunction because a dysfunction in neuromuscular junction. And in the last part, the last group, that the one where we focus on, we can have a EO dysfunction due to a muscle disorders, either an hereditary disorder or an acquired disorders. Of course, talking about mitochondria, this is one of the main syndromes and one of the main diseases we focus on this presentation. In muscle disorder, external ophthalmoplegia, most of them is progressive, is bilateral, and can be present in several muscle disorders, going, of course, or from mitochondrial disorders, but either from other hereditary myopathy as congenital myopathy, myotonic dystrophy, oculopharyngeal dystrophy, or some acquired myopathy as inflammatory myopathy or endocrine myopathy or paraneoplastic one. When we talk about progressive external ophthalmoplegia, sometimes we said also chronic external ophthalmoplegia, of course, we usually think about mitochondria. And in this cartoon, I would like to present the characteristic of progressive ophthalmoplegia. Then we think about the rule of peace is really associated with ptosis, usually, and is characterized by no pain, so painless. Usually patient has a very severe limitation in the eye movement, going from ophthalmoparesis to ophthalmoplegia, and usually this patient has no diplopia. just because of the chronic course of the symptom. In the definition, going through the Handbook of Neurology from a very expert in neuromuscular disorder, this is Professor Roland, he defined in 1992 in one of the editions of the Handbook of Clinical Neurology, the PEO as a progressive ptosis with impaired eye mobility that usually is bilateral, with a pupil sparing, with a chronic course with no remission, and where you can exclude other diseases that are more common or more frequent, such as thyroid disorders or myasthenia gravis. If you want to classify progressive external ophthalmoplegia, we can distinguish two groups: the mitochondrial group and the non-mitochondrial group that we already mentioned some of them. So focusing on mitochondrial forms. As we know, mitochondrial diseases are really a heterogeneous group of disorders with usually a multi-system involvement of different organs, where ocular involvement is very common. And the muscle of the eye are one of the most part of the eye that are involved. In this paper that was published a few years ago, coming from a revision from the Italian Network for Mitochondrial Disorders, we distinguish that three clinical spectrum of PEO: the pure PEO, the PEO plus, where it is associated with other symptoms, and then the classic syndromes that are characterized also by PEO, that are Kearns-Sayre syndrome and Pearson syndrome. In this review, coming from about 700 genetically confirmed patients, about half of the patients, more than half, has an ocular myopathy, either isolated or less commonly associated with involvement in the central nervous system. And in the PEO, we can distinguish about 60% with plus form or about 30% with pure PEO. So without going through the genetic background of these disorders, because we are going to talk about in more detail of some of these, we can distinguish two groups: the one that are related to mutation in mitochondrial DNA with the different kind of transmission, hereditary transmission, and the one that are related to variants in the nuclear DNA. So going to enter in detail about the pure PEO, usually is characterized by eyelid ptosis, ophthalmoplegia that usually is symmetrical with a slow progressive. Is a mitochondrial disorder, so usually muscle MRI show the classical markers with rugged red fiber, Cox negative, and sometimes ocular MRI that is not routinely done in patients, but I show some paper that can suggest a possible role in the diagnosis of this patient, can show some specific pattern. On the genetic point of view, the pure PEO can be associated, of course, commonly with a multiple deletion, but mainly with a point mutation that is sporadic. But there is a part of patient that is harboring a mutation in NDA, NDNA. And these are three patients coming from our cohort. The first patient is a patient with just a sporadic PEO associated with a common deletion in mtDNA. The second patient is a patient harboring a mutation in POLG with autosomal recessive hereditary transmission. And the third one is a patient with an autosomal dominant PEO due to a mutation in the twinkle gene. Usually eyelid ptosis is mainly bilateral, as we already said, is symmetrical, and the patient did not complain about diplopia. This is the patient that we already saw, and this is the video showing this is some atypical case where the ophthalmoplegia is not so striking. Instead, in the patient that we can see on the right part, he has either no, at least, movement of the eye. Were very fixed, so the real ophthalmoplegia that you should see usually in patients with a single deletion. Going to the classical syndrome in mitochondrial disorder due to single deletion, we have to talk about Kearns-Sayre syndrome that is characterized by the PEO, but associated with other clinical presentation as pigmental retinopathy with involvement of heart, with heart conduction blocks, cerebellar ataxia, and on the genetic point of view, 90% of these patients has a single deletion in mtDNA, so either this is more severe, this is still a sporadic form. Among these, we have to talk about also of a very severe syndrome named Pearson syndrome. That is a multi-system disorder where PEO is associated also with extraneurological involvement with sideroblastic anemia, pancreas exocrine dysfunction, and pancytopenia. Talking about PEO plus, so this is defined a condition where ophthalmoparesis or ophthalmoplegia is associated with other symptoms, but the patient did not fulfill the criteria of Kearns-Sayre syndrome. So usually these forms are associated with mutation in the nuclear gene and are associated with multiple deletion on the mtDNA. And these are 3 patients with 3 different forms of PEO+. The first patient is a patient with a form of autosomal dominant PEO, and this patient, behind the PEO, he has a neuropathy with an ataxia. The second patient is a patient with a POL-G variant, where PEO is associated also with leukoencephalopathy. And the first one is a patient with a PEO where the ophthalmoplegia is associated also with optic atrophy and is due to an OPA1 variant and also a Parkinsonism. In this slide, I show a patient, and these are the video showing different parts of the neurological examination. As you can see, the patient has a very severe ophthalmoparesis, ophthalmoplegia. Is a 76-year-old man who manifested some dysmetric at the cerebellar, some cerebellar sign, but either, as you can see, he has a very anemic face, and looking at the bradykinesia and the tone, we can clearly show Parkinsonism. This is a patient with a twinkle variant who started with the ophthalmoplegia, but over the course of the disease, now he's 76, he developed some Parkinsonian syndrome. This is a syndrome that we used to see in patients with mutation either in twinkle, but also in POL-G or in OPA1. Another condition that is a multi-system condition that is a classic mitochondrial disorders is a mitochondrial neurogastrointestinal encephalomyopathy that is a rare form of leukoencephalopathy. This is due to a deficiency of thymidine phosphorylase, where patient has ophthalmoparesis, polyneuropathy, and a clear leukoencephalopathy. The patient also has some gastrointestinal dysmotility that is leading to a cachectic status, and is a very severe condition where a multi-system disorder is really devastating. Among PEO plus, we have to mention also the mutation, as already we said, in OPA1 that usually are associated with an optic neuropathy, but there are different phenotype where the optic neuropathy is associated either in the same family with a PEO, as this family that we published a few years ago with the Bologna group. Also Chiara was involved, and these are two brothers. In the first one you can see a clear ophthalmoparesis with a very subclinical optic neuropathy, whether the second brother show a very clear optic neuropathy and the PEO was less pronounced, suggesting that heterogeneity, either in the presentation of different symptoms, as we already know in mitochondrial disorder, either with the same genotype in the same family. Another condition that is considered also a mitochondrial disorder is SPG7, is originally described as a mutation due to a mutation in paraplegin associated with hereditary spastic paraplegia, but we already know that variants in SPG7 can present with a wide clinical spectrum, where we can see hereditary, of course, spastic paraplegia, either cerebellar ataxia, but also progressive external ophthalmoplegia. And this is one of our patient, a 65 years old female. She had two sisters affected, and as you can see, she is a very severe ptosis with ophthalmoparesis, as you can see in this video. But also, if you see her on the video on the right, she has a gait characterized by some Parkinsonian and rigidity at lower limbs. So also in this case, we have a intrafamiliar heterogeneity. Why the external ocular muscle are so involved in mitochondrial disorder? In this nice study, 13 patients with PEO were selected, and a muscle biopsy was studied, in particular quadriceps and also the levator muscle and medial rectus muscle, so the high muscle. And in this condition, in this study, it showed that the eye muscle are very rich of mitochondria, so a dysfunction in mitochondrial energy production lead to a almost very common involvement of eye muscle. So going on the differential diagnosis in other muscle disorders, we will mention in the last part of the presentation other muscle disorder that can present with eyelid with ophthalmoplegia, either bilateral or unilateral. And among these, we can mention the inflammatory myopathy, and in this condition, usually these are a group very heterogeneous of condition, and I will share with you a case that was a patient with 3 episodes of severe pain with diplopia and with this unilateral ptosis. This is not really visible, but since you can see that this is a unilateral ptosis with some limitation in the eye movement. Laboratory test didn't show any alteration, but the orbit CT scan and the MRI show this hyper intense intensity in the muscle with increase of volume, suggesting an inflammatory condition. The patient was treated with corticosteroids with the resolution of the condition. And this is what we see him after steroids treatment, either in on the clinical point of view and the neuroimaging point of view. There are some atypical forms of inflammatory condition where eye muscle are involved, some autoimmune condition that has to take in consideration, in particular when the onset is acute or subacute, when there is pain, and sometimes some of them are not responsive to steroids treatment. Going on other hereditary muscle disorders, just a mention on myotonic dystrophy, and these are 3 patients with myotonic dystrophy. As we know, there are 2 forms of myotonic dystrophy, DM1 and DM2. Usually, the eyelid ptosis is mild, either the ophthalmoparesis. There is no fluctuation, usually is not progressive, and is associated with a myopathic phase, with a temporal muscle atrophy, as you can see in this patient or either in this. And in particular, we know that in myotonic dystrophy, there is an involvement of the distal muscle forelimbs and the extra muscle involvement with other symptoms going from diabetes, from cardiac involvement, and so on. A condition that sometimes is important to differentiate from mitochondrial disorders is oculopharyngeal muscle dystrophy. Usually is an autosomal disorders, but usually the ptosis and the ophthalmoparesis is less pronounced, and the onset is later, usually in the 5th and the 6th decade, and is associated with a severe difficulty in swallowing and sometimes with the proximal limb weakness. Is a condition due to an expansion of a polyadenylate tract in the binding protein nuclear 1 gene, and this is our 2 patients with this condition, and where you can see the severe dysphagia that can lead to a really progressive swallowing difficulty and the eyelid ptosis. And a real new condition that is similar is to the oculopharyngeal muscle dystrophy is another condition named oculopharyngeal myopathy. And this is a patient with this condition where the patient show apart from ptosis and from ophthalmoparesis, they have like the weakness mainly in the distal muscle, and few genes are associated with this condition, and are all expansion disease. In particular, 4 genes have been recently described, where with this emerging new phenotype as cause of recurrent PEO. Another condition among hereditary myopathy are the congenital myopathies. These conditions, as we know, are characterized by an early onset with some dysmorphic features. And as you can see in 2 of these papers that are reviewed the clinical features of congenital myopathies, ophthalmoplegia is either present in different type of congenital myopathy due to the variants in different genes. Among neuromuscle disorders causing external ophthalmoplegia and dysfunction in the eye movement, of course, we have to mention other conditions, in particular the neuromuscular junction disorders as myasthenia gravis or so the autoimmune disease, but also the Lambert-Eaton myasthenic syndrome and the congenital myasthenic syndrome. In myasthenia gravis, usually eyelid ptosis can be bilateral, but mostly is asymmetric or unilateral, is frequently associated with diplopia. Usually the condition is fluctuating with the worsening with fatigue, is associated with muscle weakness. As we know, we can distinguish two types of myasthenia, the ocular myasthenia gravis, where the muscle weakness is restricted to the eye and the eyelid muscle. It is about 10 to 40% of all cases, and usually has a general good prognosis. And then the generalized type of myasthenia with a widespread muscle weakness and with the prognosis variable depending on the disease course and the muscle affected. Characteristically, eyelid ptosis myasthenia gravis can be reversible with this test, in particular with the EYES test that is usually used as first diagnosis step to distinguish a patient with myasthenia gravis. Also, congenital myasthenic syndrome, as we know, are very rare, are very heterogeneous, and now I can show a few patients with this condition. This is a 6-year-old patient with a bilateral ptosis and extraocular muscle weakness since she was 6 months. She has a neurophysiology test that was shown at decremental stage, and molecular diagnosis was able to identify a variant in CHRNE gene. This patient was treated with the inhibitor of acetylcholinesterase with a good outcome. So it is important to think about this condition, and because we have some clues in the therapy that can improve the quality of life of this patient. And this is another patient coming from a family of 3 sisters coming that with consanguineous parents. The patient has a bilateral ptosis with ophthalmoparesis, and 2 of them experience, this is a very important clue in the diagnosis, respiratory distress when with prolonged ventilatory support. And the picture shows the patient before adjusted treatment with the inhibitor of acetylcholinesterase. So also this condition is treatable, and so it's important to identify. This is the last form that I want to show, is a Miller-Fisher syndrome. Is a variant of Guillain-Barré syndrome that is characterized with this subacute onset of eyelid ptosis and ophthalmoparesis, with associate also with ataxia and areflexia. Is an autoimmune condition associated with these antibodies in the cerebral fluid spine, and these patients is important to identify because they respond well to IgG therapy. I was mentioning about the role of muscle MRI. This is a study that define the feature on MRI, on muscle MRI in different neuromuscle condition, and focusing on mitochondrial myopathies. We see that comparing with the healthy subject, usually muscle are hypertrophic, and comparing with a condition that is common, that is grave orbitopathy due to a thyroid dysfunction, where there is instead a volume increase. A few years ago, a study on muscle MRI was done specifically in a group of patients with mitochondrial disorders, and 9 patients with PEO were compared with 9 control. And in this nice study was shown again that the extraocular muscle were atrophic, with some characteristic signal change on T2 sequences. And in this study showed that the grade of atrophy was correlated also with the limitation range in the eye movement, suggesting as a potential biomarker of disease severity. So if we want to conclude this presentation, this is a overview of all the characteristic clues that can help us in the diagnosis of extraocular muscle dysfunction in neuromuscular disorders. So if we have an ophthalmoplegia due to a muscle involvement in the presence of ptosis, we have to consider if this is symmetrical and if how it goes over time. So if it's fluctuating, so just think a neuromuscle junction dysfunction, but if it's symmetric and is progressive and is not fluctuating without pain, of course, consider muscle disease, and particularly, of course, PEO due to a mitochondrial dysfunction or either a condition as the oculopharyngeal muscle dystrophy. For this, I will finish my presentation, and now I'm ready for some answers. Thank you.
Thank you very much, Olimpia, for this nice overview, very complete, thank you. Let me see if there are any questions in the chat or QA. I cannot see anything, but in the meantime, while someone is maybe making any questions, I can ask you something, Olimpia. So you mentioned briefly the genetic flow chart that you should take in case you suspect a mitochondrial CPO. Which one would be the best genetic flow chart you have in mind in the case of mitochondrial CPO?
Yeah, of course, we focus mainly on the clinical point, but the genetic diagnosis is important, as we know now in the modern way to study patients with muscle disorders. Sometimes genetic is coming first, other diagnostic procedure, and it's important to consider, for example, that we run a genetic test using the next generation, for example, sequence panel, to consider that there are some conditions associated also with PEO, but also in other muscle disorder where due to nuclear sequence expansion, as for example oculopharyngeal dystrophy, or this new form of oculopharyngeal distal dystrophy that you cannot see on NGS panel evaluation. So you need to run a specific test to identify the X function. This is important to think about this in order not to miss the diagnosis. And this is something that is very important, either in other conditions that we know.
And in the case you mentioned the single deletion, in this case the muscle biopsy is very relevant.
Of course, I didn't say anything about the genetic or the diagnostic process on mitochondrial disorders, But as we know, if we are going to check a single deletion in mtDNA, is important to select a correct tissue. So it's important not to do it on blood as we usually do for nuclear mutation, but it's important to use tissue that are rich of mitochondria, as of course muscle first, but also urine or other tissue that we know, and just not to, because otherwise we can miss either the diagnosis and we cannot detect the single deletion. That of course, talking about mitochondrial disorders with PEO, sporadic is the most common and the first thing to think when we see a patient with ophthalmoplegia and without other symptoms, and already where we already have excluded other more common condition, acquired condition.
Yeah, so in those cases, muscle biopsy remains a gold standard for diagnosis, for detecting the
Yes,
single
I completely agree. Of course, also the morphological study help you in the diagnosis, because usually in patient with PEO, you see the morphological mitochondrial markers as rugged red fibers or COX negative, FTH blue fibers that maybe are not so are not always present in other mitochondrial conditions, but in sporadic PEO are usually present.
Okay. And on the clinical ground, you say that usually you have bilateral ptosis and usually don't have double vision, but you have, in your experience, mitochondrial patients with some double vision. You think it's something that you can...
This is what we say, but of course there are exceptions, and this is important to think about in the diagnostic process, but either in the follow-up of this patient. There are some patients that can develop diplopia, maybe in some condition that can stress muscle, maybe some or either during infection, or when the muscle are weaker, and then they can complain of diplopia, although the ophthalmoparesis is progressive, it's chronic. So this is something that it can appear, and it's not an exception.
Okay, let me see if there is any question. I cannot see anything. And in terms of the eyes test that you mentioned, because sometimes I usually do the eyes test in the presence of this condition, and I found sometimes that the eyes test is positive even with the mitochondrial patients. Is your experience as well, or?
Actually, I don't have experience on mitochondrial patients, but of course, this is the first test that we used to do in the first part of the diagnostic process in myasthenia. But then on the bed of the patient, when we see the patient, the outpatient, for example. But is suggestive of a neuromuscular junction disorder, of course, is not the definite diagnosis that we can have just with the iSpot test. We have other tests that we can use, of course.
And I remember in the few cases where I did this test, the response was not so obvious as you usually notice in the myasthenia, ocular myasthenia. So it's just a very not so relevant, I mean, in terms of response.
Yeah, because considering the frequency of these two conditions, usually the first differential diagnosis when you see a patient with ptosis or ophthalmoparesis is first of all with myasthenia, because sometimes, of course, it depends on the center where you work. Of course, we are focusing on mitochondria, so to our counts, usually patients come patient with already where myasthenia was excluded. But sometimes comes patients that still they think they have myasthenia, and then you have to to say that it's not, because because they have no antibody, because the neurophysiological studies are not suggestive, because they do not respond to the therapy, and because then we go further in the diagnostic process and we define the genetic alteration. So this is something that we usually have to face up in our clinic. I don't know if it's your experience also.
Absolutely, and in those cases, maybe the main clue is the fluctuation of symptoms that helps in the differential, because you know the ptosis is variable during the day, but it's the main differential. I agree with you.
Yeah, I consider it also with oculopharyngeal dystrophy, because sometimes you can diagnose later a patient with mitochondrial disorders, and OPMD can be in the differential diagnosis, because usually mitochondrial patient, the PEO and the ptosis comes earlier, usually over the 20 to the second, the third decade, or even before. But sometimes when you see a patient, a 50 years old patient with PEO, of course, and not so obvious dysphagia, that apart, we didn't say, but dysphagia is also present in patients with mitochondrial disorders. So sometimes it's still a challenge to distinguish the two conditions. Either in presence of a dominant transmission, because of course we have mitochondrial PEO with a dominant transmission due to nuclear DNA mutation, and with dysphagia, and with a later onset. So then the diagnosis can be done, of course, with muscle biopsy, and then at the end with the genetic test. Because on the morphology part, on the morphological study of muscle, also OPMD has some clues that can help you in the diagnosis. But so far, usually we go for genetic first. We don't do muscle biopsy in a suspicious of OPMD. I don't know if you do it like this.
No, I mean, this is something that we do in the suspicion of mitochondrial form, but not, I agree with you.
OPMD, because of course the genetics, it's not so easy, because to find the expansion is not so easy, but it is a monogenic condition apart from the distal forms, and so easy to do genetics.
Yeah, and sometimes, you know, it depends to choose to do the first the genetic before muscle biopsy. If you have a clear familiar history suggesting an autosomal dominant pattern, not mitochondrial DNA pattern, I mean, you can escape the histology, but sometimes you need, especially for the sporadic cases, as you mentioned.
Yeah, I agree. There are no questions from the audience?
I cannot see any. Let me see here.
I see some.
You see? Because in my, no.
No.
Okay. I think we saved some time. If there are no more questions, we can close a little bit early.
Okay, maybe we are a bit early, but do you have a patient with this distal oculopharyngeal dystrophy?
No.
No.
Maybe I didn't recognize them. I don't know, but no, in my experience.
Mine is a recent diagnosis. This was a very big family that since several years was diagnosed for a mitochondrial myopathy, but without genetics. I mean, everything going from single deletion to multiple deletion to didn't find anything, but there was a clear dominant transmission, And in the first patient with the respiratory involvement also, no cardiac involvement, but in some members, there was a very clear distal myopathy that was, you were thinking about a neuropathy. Instead, was a myopathy because of the EMG, myopathic EMG. So it was a distal myopathy with this PEO and respiratory involvement. And also the exome didn't show anything. And then we check about this expansion, and we found a mutation in one of the genes that are already reported. So this is something that for me is quite new. I mean, I didn't know very much about this group of disorders, but we have to think about either in patient without the diagnosis, because all of us as patient with a clear PO and with no genetic definition. So this is something that we can think.
Yeah, I also recently saw two brothers with the distal myopathy. For those cases, we found the recessive form of POLG, which is, uncommon even for polymerase gamma to have distal myopathy. But, sometimes there are already cases reported in the literature with this appearance. So
yeah,
it's
of course.
an unusual presentation as well. Okay, I think that at this point we can close the webinar. Thank you to all the attendants and to the organizer and for the all webinar series on mitochondrial disorders. We hope to do again next year and see you maybe next time.
Okay.
Thank you, Olimpia, for
Thank
your
you.
presentation.
Thank you.
Thank you very much, Olimpia. Thank you,
Bye.
Clara, for everything.
Bye.
And see you next time.
Okay.
Bye-bye.
Bye-bye.
Bye.
Bye.